Okay, so now this should be recording. So we're going to go ahead and do the pediatric admission assessment. All right. Promoting a positive experience for the children. The attitude of the nurse and the other healthcare professionals makes the difference between a warm and friendly environment and one where the child feels dehumanized, okay? It's very important for children to have positive experiences in the hospital and office settings. I don't know if any of you have children or have been with children where they're like, I'm scared to go to the doctor, and we don't want that to happen. So you want to try to make the most positive experience as you can. All right, parents should always be involved whenever possible in the child's care. And this is from the Leafer book, and I think that, I hope it's the correct box, still 21-1. I don't have any new notes on this one, so I'm hoping that's the right box. If it's not, somebody let me know and I'll look it up. In preparing the child for treatment, so there's different things we're going to do for different age groups. We've got the toddler, the preschool, the school age, and the adolescent age group. So for the toddler, we're going to model behavior. You know, if we want them to open their mouth so we can see their throat, we're going to open our mouth. You know, it's okay for them to yell if they're uncomfortable or to use distractions. A lot of times, toddlers and preschoolers, in the preschool age group, you want to allow the children to handle the equipment. So you can give them your stethoscope or, you know, the pen light or the tongue depressor or a pair of gloves. You know, just let them hold things, manipulate them, handle things. That really helps them not be so scared of what's going on. In the school age child, you want to explain in advance what you're doing and why you're doing it, and let the child help if at all possible. If there's a procedure that the child can actually help you with, you know, let them assist you. In adolescents, you want to explain the procedure in detail, encourage questions, involve them in any decision making. I mean, they are like almost adults. Obviously, we're going to make the choices that need to be made, but we really want to include them in the process. Okay. Collecting information, subjective. We're going to ask questions, do a review of systems, and usually we're going to go head to toe on that with our subjective assessment. And then our objective is our hands-on. So when we start doing the hands-on assessment, we're going to go from least traumatic to most traumatic. So that may not necessarily be head to toe. Usually it is still head to toe, but not necessarily. All right, the child can sit on the parent lap during the exam if it makes the child more comfortable, and this is usually what happens. This is usually the best option for parents and children, because parents are a little bit leery also. Their kid's in there and their kid is nervous, and so that makes the parents nervous. And so that is often something that a lot of physicians and nurses will do, is just to let the child sit in your lap, and they'll do as much of the exam. When they're really tiny, they can pretty much do the whole exam in the parent's lap, and they will do that if that's, you know, if that's possible, to make the child feel more comfortable, especially when they're in that preschool, toddler, preschool, stranger danger, you know, phase where they're scared of everybody. They will definitely have them sit on the parent's lap. All right, skin turgor, objective data collection with skin turgor. How do we assess the skin turgor on an infant or toddler? We've talked about this, I think, just last week. So how do we assess skin turgor on an infant or toddler?
On the abdomen?
Yes, we're checking on the abdomen. All right, pinching up the skin on the abdomen. We're assessing the skin color. Is it pink, pale, gray, mottled? And sometimes mottled skin color is not abnormal. It's kind of a lacy, like pink and white appearance. I think I may have a picture as we go. Where are we going to assess for cyanosis? Where's the best place to assess for cyanosis?
Buccal.
Yeah, the oral mucosa, the buccal mucosa, and mucous membranes, definitely. So as far as we're looking at skin color and cyanosis, there are normal newborn findings that we may think would be abnormal, but they are actually normal findings. Does anybody know what types of things those are?
Their like nails are kind of like purplish tint.
Yes, so their hands and feet are purple or bluish purple, and that's not necessarily a sign of cyanosis. That is called acrocyanosis, which is very normal for newborns. Now that changes, you know, pretty quickly, but in those first couple of hours, especially of life, or even those first couple of days, that's a very normal finding. So that's nothing to be alarmed about. Their circulation is just not developed yet. Excuse me. Milia is another one. We're going to talk about milia and different birthmarks here in just a second. Bruising. So kids have bruises all the time. Where is it normal to find bruises on children?
Knees.
Knees. Where else?
Elbows.
Elbows. Yeah, any bony prominence, shins, elbows, knees, those are normal findings. There are places that are not normal to find bruising, like what?
Back.
Yes, the back. Well, it kind of depends. If it's on the spine, that could be okay because of the bony prominence. But yes, the back.
Their head.
Their head potentially. Although again, sometimes that's normal too. It kind of depends. Not the back of their head usually, because they usually fall forward. So it's usually a bump on the front of their head or a bruise on the front of their head. Ears, they have bruising on their ears. That's not normal. They have bruising on the backs of their arms, like it's been pinched. You know, that's not normal. On the backs of the legs, areas that they can't reach and they're not likely to fall and hit, you know. Those would be abnormal places. But normally we are going to find them on bony prominences or legs or anything. Scars and birthmarks must be documented, and we're going to talk about that. It's really important to document any of these scars and birthmarks at birth. A very good head-to-toe skin assessment is super important for newborns in particular, because if we aren't documenting that and then they go to their first pediatric visit and the physician notices these areas that look concerning and there's no documentation from when they were in the hospital, they're automatically starting to think something may be going on, and nothing may be going on. It may be a lack of someone not documenting like they were supposed to. So you need to be sure that you're documenting that. All right, so skin. We've got Mongolian spots. These are a normal birthmark finding that you would find in children, usually in darker skinned babies. This is a dark or blue-black discoloration, usually found on the buttocks or shoulders. And this right here is an example of a Mongolian spot right here. So you can see that if we did not document this when the baby was born and the baby comes in for its pediatric visit, I mean, we're going to be super concerned, right? So we've got to be sure that we're documenting these things. We may, the baby may have a port wine stain, which is a collection of capillaries in the skin. It is flat. It is usually a purple or red color and lesion. It does not blanch with pressure. I'm going to show you some pictures here in a sec. Nevi, these are what they call stork bites. Y'all heard of stork bites before? So usually they're kind of up here between the eyes or on the back of the neck, on the nape of the neck. They're pink, they're easily blanched. They're found like in the eyelids, the nose, nape of the neck. Milia, these are little white pinpoint papules on the face, usually across the nose. And they look like pimples, and you got to make sure that the parents know not to pop them or anything like that. All right, erythema toxicum. These are splotches with firm yellow-white papules all over the body with a red base. They look bad. They look very irritated and inflamed. They look very uncomfortable, but they are not a problem for newborns. It's a very common newborn rash, this erythema toxicum is, and it's not uncomfortable for the infant. It looks very uncomfortable, but it doesn't. Again, you've got to just ensure that the parents aren't picking at these places or popping these places, because what happens if we pick or pop these little places? What's the problem?
Increased infection.
Right, we're very much increasing our potential risk for infection. Modeling, that's this, it's a lace-like red or blue pattern on the skin surface of a newborn. Epstein pearls are these little white pinpoint papules that you'll find in the midline of the upper palate in the roof of the mouth. And then acrocyanosis we talked about, which was that cyanosis, the bluish coloration of the hands and feet, usually in that first week of life, and it's related to vasomotor instability. So here's what we've got. Mongolian spot right here. This is erythema toxicum. You see how that just looks angry. It looks like a nice angry rash, okay? And the parents get really concerned about this, and it's usually all over their bodies just like this. And it's nothing to be concerned with. It's something we have to educate and, you know, comfort the parents that this is not a problem. It's not causing the child any discomfort, but this is a very normal rash. This right here is a port wine stain, where it's just these, the capillaries there, this flat, red, non-blanchable lesion. Right here, we've got the stork bites, right here between the eyes. So these are lighter in pink, light pink, much different than the port wine stain, and you can blanch these when you touch them. And there's my picture for acrocyanosis. Can you see how purple these hands are? I mean, all the way up to the elbow here, and that's okay. This is a normal finding of acrocyanosis. What is this? You may know. Can y'all see what I'm pointing to? Nobody knows what that is?
Is it the Malia?
No,
Is it
it's actually something we haven't talked about yet. What'd you say, Abby? It's okay. We haven't really talked about it.
Are we not? We're not supposed to wipe it off, are we?
Yeah, we're not supposed to wipe it off. It's kind of like the smegma, but smegma you find in the genital area. It's vernix. This is vernix, and it's this thick. Up in here, you can wipe it off, you know, with some warm soapy water. Usually we will get most of it out of their creases of their neck. It's in their elbow and their antecubital spaces, behind the knees when they're born. And we usually get all of that out with soap and water in their first bath. But you'll have a lot more usually in the genital area, and that's what we don't want to be rubbing to get off. And then this right here is an example of a hemangioma. So it's raised, very red, raised lesion versus the port wine stain here. Okay. All right, so we've got vernix. So that was what I just showed you on that other picture. It's that white cheesy substance that protects the skin in utero. We've got lanugo. Does anybody know what the lanugo is? We find this on newborns also. It's this fine hair that covers the infant's back, shoulders, arms, and as they age, as they increase their gestational age, they that lanugo thins out. Same thing with the vernix. So the older your baby is when it's born, if it's a 39-week baby, a 40-week baby, will have less vernix, less lanugo. If we have a 36, 35-week baby, we're going to have more vernix and more lanugo. All right. Milia, those are those little tiny white papules on the face. Harlequin sign, this happens when you have one side of the body turns red and the other side turns pale or white, usually when the infant is crying. I have honestly never seen it, but it's amazing. Got a picture for you. And then jaundice is a yellow coloring to the skin. All right, same thing we just talked about earlier, bruising in areas other than the knees, shins, lower arms, lower legs may indicate other problems such as potentially abuse. I really hate jumping to that conclusion, but we also have to be on alert for these things. I just went to a pediatric conference right before all this COVID hit, right before spring break. And they were discussing some of this, just making sure that we all are all aware of our responsibility to report these things and knowing what to look for as potential signs of pediatric abuse. This right here is a very preterm baby. Look at all this vernix. This is all vernix. Lots of cheesy like substance on there. Lanugo, Now, sometimes you'll find a lot more hairy, this darker colored hair, especially up on the tufts of the shoulders in darker skinned babies, dark complexion, but this one is still a whole lot. This is definitely a preemie with all of this hair. And this one right here is the milia. It looks like little tiny pimples across the bridge of the nose. And this is an infant with Harlequin sign. I mean, very red on one side, very pale on the other. Usually this occurs with crying. And this is a picture of the jaundiced infant. Look at how much more jaundiced this baby is than this one. Sometimes it's hard when you're just looking at one kid to say, is this baby jaundiced or not? But you compare the two, it's very drastic. And you can also blanch the skin and be able to tell as well about the jaundice. All right, we're going to get a height on the child and a weight. And again, we want to weigh them at the same time of the day on the same scale with the same amount of clothing. Even the infants, we, like in the nursery, when I was working in the hospital, we weighed the babies every night. And so you took the, you wrote down what scale number you had, you would take the scales around, or we did it many different ways. Sometimes the babies would come to the nursery and get weighed, stock up their cribs. Sometimes we went to the rooms and weighed them and stocked up their cribs. But regardless, they got weighed on, we tried to do them on the same scale. Always weigh the infants naked. These little bitty infants, young children that can't sit up yet, you're going to weigh them naked. And you want to be standing right there close by. You have to put a little piece of, this one has a blanket on there, which is fine. So a lightweight blanket or a, thin piece of paper, like when you go to the doctor's office, they have that paper over the tables. They have this little paper that they put on the scales, and you use one per infant, and you put this paper on the scale, and then you zero the scale, then you put the infant on there. You always want to stand close by and have your hands right over the baby, because even though technically they can't roll over or sit up or anything, you never know what they can do, and you should never ever leave an infant unattended. So you're going to stand right next to the infant, get the number, and then transfer the baby back to the crib or whatever, put the diaper back on, dress the baby, wrap the baby up or whatever. If you have to weigh the baby with the diaper on, you need to weigh the diaper separately as well. So they have scales that go to the tiny, they have literally, it's like kind of like a food scale, and they put the diapers on there. So you would weigh the diaper, put a clean diaper on the baby, weigh a clean diaper alone, put a clean diaper on the baby, put the diaper on the scale, put the baby on the scale, weigh the baby, and subtract the weight of the diaper from the weight of the infant. All right, head circumference is measured routinely at routine visits until about 2 to 3 years of age, and that's what they're measuring right here, just right above the eyebrow, above the ear, and to the occiput there, where that little part sticks out on the back of your head. It's normal for a newborn to lose weight initially, right after birth. So what is the normal amount of weight? How much weight is okay to lose?
Like 1 pound.
Well, you can't actually do it by pounds. You have to do it based on
Grams.
Because it depends on what their birth weight was. So you can't necessarily say 1 pound, 2 pounds, 3 pounds, because that makes a big difference if this is a 2-pound infant versus an 8-pound infant. So how do you think you do that?
Maybe by ounces?
Well, again, that's still just going to give us an exact number. We can't do an exact number because every baby is going to weigh something different.
You just always compare it to the birth weight?
Yes, you compare it to their birth weight. So they should not lose more than 10% of their birth weight. It is normal for them to lose weight. They should lose weight. They're going to lose some weight initially right after birth, but they should not lose more than 10% of their birth weight. Okay, they're losing fluids, they're finally voiding, they're not eating as well. Then we get to about 5 to 6 months of age, and how much should they weigh? Again, it's not going to be an exact number. It's got to be based on their birth weight. So what do we know? What's going to happen about 5 to 6 months of age?
Should it double?
It should double. Their birth weight should double. And then it should triple by when?
A year?
By 1 year. So initially baby's gonna be born, the baby weighs a certain amount of pounds. It can't it should not lose more than 10% of its birth weight. That's kind of the number we're looking at, and that's different for every baby. That's why we can't say 1 pound or so many ounces, 6 ounces, because it differs for each child, how big they were when they were born. But they shouldn't lose any less than any more than 10% of their birth weight. Then by the 5 or 6 months of age, their birth weight should double. And by 1 year of age, their birth weight should be tripled. So we can go ahead and know how much the baby's going to weigh at 1 year, or should weigh at 1 year of age, based on their birth weight, because we know it should triple, right? All right, the fetal head, we've got sutures. This is where 2 cranial bones meet. You don't want them to be fused together for an infant. Our cranial bones are fused together, and this is how it should be for adults, but for infants, their cranial bones should not be fused together, because they have to overlap during the delivery process to be able to be delivered vaginally. All right, you've got fontanelles. You have 2 fontanelles, an anterior fontanelle and a posterior fontanelle. So anterior at the top, posterior at the back, and they should be full, but not bulging. You shouldn't have a bulging fontanelle that sticks up, and you shouldn't have a sunken fontanelle that sinks down in their head. You know, this is what everybody talks about, the baby's soft spot. That's what they're talking about when they say, be careful of the baby's soft spot. Well, that's what they're saying, is this is fontanelle, but this is a good way to assess how the baby, you know, if the fontanelle is bulging, what might we be concerned with?
Hematoma.
Potentially a hematoma.
Would it be like their brain? Something about their brain?
I didn't hear you, sorry, what?
Their brain maybe swelling?
Well, not necessarily the brain, but yes, you're both kind of on the right track. We'd be really concerned with maybe some potential intracranial pressure, increased intracranial pressure in the head, yes. And what about if it's a sunken fontanelle? So if the fontanelles are sunken, what are we concerned with?
Dehydration.
Yes, we're going to be concerned with potential dehydration. So that's what you want to watch for with that. Then molding, that's the actual overlapping of the cranial bones. That's called molding, and that's what we want to happen. We can get a caput succedaneum, we just call it caput, which is the swelling of the soft tissue over the presenting part of the fetus, which is usually, you know, whichever part of the head presents, you will have the swelling. Now, a caput does cross the suture line, so I'm going to show you some pictures to help you see the difference, because a cephalohematoma is very similar. It is swelling from some bleeding, and I don't mean bleeding in the brain. It's just like bruising on the head, on the scalp from delivery. But a cephalohematoma does not cross suture lines, and so one way people remember this, I probably have a thing in here, no, I don't. A CS for caput succedaneum, crosses suture lines, CSCS. That's how sometimes people will remember that. But so right here, this is showing you the anterior fontanelle. This is the soft spot people speak of, and the posterior fontanelle, and this is caput. Okay, so caput, swelling of that soft tissue, crosses suture lines. This is a cephalohematoma. Notice how it's only on one side of the head, very specifically this collection of fluid and blood on one side of the head specifically. And this is molding. Okay, so this is where the sutures have, the bones have crossed over to mold so that the baby's head can fit through the vaginal canal. And all I can think of every time I see that is Conehead stuff that they used to do on Saturday Night Live, but that's really old. Y'all probably don't know anything about that. But it does all go back to normal, very, you know, within a, I can't give you an exact number, and it varies for each infant, but it does go back. And if they're concerned with it, they do monitor it pretty closely if they're at all concerned, but usually it's not a problem.
So, Miss Matthews, those are normal findings?
Yes, they can be very normal findings, yes.
Okay.
All right, so with the eyes, the color of the eyes is usually a blue-gray color for fair-skinned parents, for darker eyes for darker-skinned, you know, if the parents are darker-skinned. But infants don't get their permanent eye color until about 6 to 12 months of age. So when babies are first born, everybody's like, oh, her eyes are going to be blue, because it seems like every baby's lighter skinned have the lighter blue-gray eyes. Well, that's not necessarily what it's going to remain. Okay, their permanent eye color is not until they're about 6 to 12 months of age. They have uncoordinated eye movements. You may know what that's called.
Strabismus.
Oh no, but that's a good one, strabismus. That's a good answer. It's doll's eye. They have doll's eye movement. So you turn their head, but their eyes may go like the opposite way. You know, like a baby doll, when you turn the baby doll's head, the eyes go the opposite way. That's a normal finding. Okay, uncoordinated eye movement like that with doll's eye movement is normal. They do have tearless crying because the lacrimal ducts are underdeveloped. Until what age? At what age would you actually find tears for infants? Jen says 4 months. Close. It's about 1 to 3. So 1 to 3 months of age, that's when we will actually start seeing tears. Before that, the lacrimal ducts are just underdeveloped. The eyes should be symmetrical. Visual stimulation is important in newborn care and development. And so I can't remember, I tell so many stories, I can't remember who I've told which story to, but which semester I've told which story to. But in newborns in particular, one thing we have to be careful of is we tend to be creatures of habit as well. So we put like a little, I don't know, my kids had like this little fish tank thing that had lights on it and sounds and made music and everything, and it was on one side of the crib. Well, if we put the infant in the crib with the head always to the right, let's say, and the fish tank thing is on the far side of the crib, then they're always turning their head to the right to see the fish tank. And then they can get actually this kind of like a stiff neck torticollis in their neck, where they can have trouble moving their head and neck because they're so used to looking just this way to see that fish tank. So you either got to rotate the child in the bed or move the fish tank around. Black and white stimulation is really good for infants to see. Different black and white colors are really good. But visual stimulation is something that is really important. All right, the nose. The nose, babies kind of have a flat nose. If you notice in that picture that I show you with the Milia, the baby's nose was pretty flat. That's pretty normal. They are obligatory nose breathers, which means they don't breathe through their mouth like we can. They have to breathe through their nose, okay? Sneezing, they sneeze a lot to clear nasal obstructions because they can't blow their nose or anything like that. So just because they sneeze doesn't necessarily mean they have a cold or they're getting sick. That's how they clean out these nasal obstructions. Now, they can have nasal flaring. Is that normal?
No.
Is nasal flaring normal? I heard one person, but I didn't hear what they said.
Oh.
No, nasal flaring is not a normal response. If we see nasal flaring, what does that mean?
I can't breathe.
I can't hear you.
Respiratory problems?
Yeah, respiratory distress. The infants in respiratory distress if we see that nasal flaring. Can newborns smell?
No.
No?
They can?
They can.
Yes.
Newborns can smell. They know the scent of their mom. So that's one of the things that helps them with breastfeeding. One of the things we will often have people do, like if they've got babies in the NICU, is to tell the moms to sleep with something, a little blankie or, you know, some kind of little lovey thing or whatever, so that they get the mom's scent. And then they will put it in the crib or whatever, the isolette or whatever with the baby, so that the baby has the smell of the mom, because they can smell. They know the scent of their mom. All right, the mouth. We should have moist pink mucous membranes. We need to evaluate for suck and gag reflexes and check for an intact palate, hard and soft palate. So usually the way you do that is with your pinky, obviously your hands are gloved, and you take your pinky finger and you go down the roof of the mouth and you're feeling the hard palate back to the soft palate. Once you get to the soft palate, the baby should gag. and then you come back up to the hard palate and try to get them to suck, and they should be able to suck on your finger. So in that one thing, you're checking the hard palate for intactness, the soft palate for intactness, the gag reflex, and then you're coming back up and getting them to suck on your pinky, and you're checking that gag reflex. Yeah.
So on infants, is there like a time frame when they should develop a normal suck? Like
Right away.
Okay, because I mean, how do you fix a baby who has, you know, a bad suck reflex?
Oh, how do you fix it? I like that. You don't necessarily fix it. Sometimes on premature babies in particular, you almost have to train them. So we do lots of different things like chin support, chin thrusts while we're trying to feed them, to get them to recognize that there's something in their mouth. We rub your finger or your nipple along the roof of their mouth to get them to realize that there's something there to latch onto. So yes, not every baby sucks great. Every baby does suck, well, usually, but not every baby sucks great. So if you're having feeding difficulties, we do these different training mechanisms. If they don't suck real great, maybe they have a NG tube down because we're having trouble feeding them or what have you, and we're working on trying to get them to suck, then we can, once they do any type of sucking, we can give them the formula or the breast milk so that they, you know, it's kind of like the Pavlov's dog, you know, they suck, they get food type thing, so that we're kind of training them to learn how to suck. Does that make sense? Okay. Epstein pearls are in the mouth. We already discussed these small white cysts on the hard or soft palates, can be on the gums as well. Some infants have precocious teeth. That means that some infants are actually born with teeth. If that happens, we get a dental consult to determine if they need to pull the teeth. Why would we need to pull teeth on an infant? If the infant has teeth, like, why would we take them out?
If a mother is breastfeeding?
Well, that would make it super uncomfortable, but that's not, we will not pull them just for that. She can still breastfeed. What do you think the risk is if they have teeth?
Swallowing their teeth?
Choking, yes, it's a choking hazard. So they do a dental consult to make sure to figure out what's really going on with these teeth, how embedded are they, what's the root system like, et cetera, because the concern is a choking hazard. Yes, it's going to make breastfeeding super difficult, but it is possible. Because a lot of moms will breastfeed even after their infants get teeth. So that's doable. The big concern is, could they potentially fall out and cause a choking hazard? Thrush. So thrush is when they get these white patches in their mouth or on their tongue. It is a fungal infection. If the mom is breastfeeding, you have to treat the mom as well as the infant. You have to clean all the toys, pacifiers, nipples, anything that goes in the baby's mouth has to be sterilized, boiled, or run through the dishwasher to try to get rid of that fungus. And they do a medication on their mouths. And then if mom's breastfeeding, she takes oral medication as well as maybe treating locally her nipples to help heal this. And sometimes thrush can last, and it's really uncomfortable for mom and baby. All right, ears. With the ears, the penis should be flexible with good recoil. So just like ours, we should be able to pull down and it pops right back up. The top of the penis should be even with what?
The corner of the eye.
The outer canthus of the eye, yeah. The hearing screen is done before the infant leaves the hospital. The pre-auricular tag, what is pre-auricular? Yeah, before the ear, pre-auricular, before it's before the ear. So pre-auricular tag could indicate renal issues as the kidneys develop at the same time as the ears. If we have low set ears, if they are not in line with the outer canthus of the eye, we may have a potential congenital condition that we need to look into. All right, abdomen and GU. Bowel sounds occur how soon after birth?
2 hours?
Within 2 hours after birth. The abdomen should be soft and without masses. You're going to assess the umbilical cord for signs and symptoms of infection. So what would we see that would indicate potential infection?
Odor. Yellow.
Odor, there could be an odor.
Drainage.
Drainage.
Redness.
Redness. Yep. Redness, foul odor, yellow or green drainage, or active bleeding. Okay, would be things we'd be telling moms to look for. We're assessing for possible umbilical or inguinal hernias, which we've talked about before. If they have a outy belly button, it's not, could be that they've got a umbilical hernia there, that the muscles haven't closed all the way around there, and so they will watch that, and usually they'll outgrow it, but it does need to be monitored. And then as far as GU goes, we did that GU lecture earlier, the pediatric urinary and bowel lecture, so you want to refer back to that as well. All right, extremities. Flexion is the normal position for infants, so their arms and legs should be flexed. What is syndactyly?
When they have like two fused together.
Yes, it's fusing or webbing of the fingers or toes. That's what syndactyly means. What's polydactyly?
More than two fused together?
No, it's a good guess though.
Is it like extra? Like
Yes.
it has more than the normal number, I guess?
Yes, so if you have more than 10 digits on a hand or a foot, it's very common for infants. I don't want to say very common, but I've seen it. It's not like off the wall or anything to see like an extra pinky or an extra thumb digit. And then that has to be assessed to determine is there bone in there or not, and how are they going to remove it. Sometimes they can just tie it off. If there's no bone involvement, they can just tie it off and it will die and fall off. Sometimes it requires surgical treatment.
Is that only for hands, or is that hands and feet?
No, hands and feet.
Okay.
Yeah. The simian crease, what's a simian crease?
Is it a line across your hand?
Yes, so it is a crease in the palm of your hand that is indicative of Down syndrome. So if you have a single crease, these infants will have just one single crease through the palm of their hand, and that's indicative of Down syndrome. We're assessing brachial pulses, making sure that they're present and equal. We're assessing creases over the bottom of the infant's feet because that helps us to assess gestational age. If they're premature, they have few lines across their feet, few creases on the bottom of their feet. If they are post-term, they're going to have a whole lot of creases across the bottom of their feet. Femoral pulses, we're checking femoral pulses to make sure that they're present and equal. And the physician, we don't do this, but the physician will evaluate for hip dislocation. There are two tests, Ortolani's and Barlow's tests that they'll do. You don't have to know that right now, but that they will do to evaluate for hip dislocation, congenital hip dislocation. All right, for the back and rectum, the spine, we want to make sure that there are no lumbar or sacral curves noted, no masses, openings, dimples, or tufts of hair, and that is something that we do check frequently, or that we are careful, I guess, about checking is for a sacral dimple. So sometimes right at their bottom right, it's just right at the end of the spine. It's not down with the anus. It's literally right as the spine curve, the curvature of the spine there. If they have a really deep dimple right there, we will assess it to make sure we can see a bottom to the dimple. Sometimes they will actually send them off for x-ray or MRI testing to make sure that there is a bottom there, because what they're concerned about is if they have this sacral dimple and this tuft of hair there, they could be indicative of spina bifida. Even though we don't have anything on the outside, this may mean that things haven't closed completely like they should have. So that's what we're looking for with that. We are going to make sure that the anus is patent, and we will know that if the baby's stooled yet. What is meconium?
The first bowel movement.
Yeah, the baby's first bowel movement. It's it's black, it's tarry, it's real thick and sticky like. It does not have an odor to it. So if the parents are waiting to smell the baby's dirty diaper, it's not going to happen. So you need to make sure that they're changing these diapers frequently, not waiting to smell the dirty diaper, because they're not gonna. We're assessing for symmetry of the back in older children, particularly. Assessing for scoliosis. Do they have a shoulder hump on one side? Are the hips uneven? Just as this picture here shows, that's what we're looking at or trying to assess with our, you know, if there any curvature. Notice how uneven these hips are, these uneven shoulders. The scapula sticks out further than the other. That's a shoulder hump. The things that we would be looking for. And note their gait and posture when they're walking. Okay, that will help too. Oh goodness. Just move something. Okay. Neurologic assessment. So hypotonus or hypotonic is flaccid, and hypertonus or hypertonic is an infant that's real they're real spastic and tight and jittery. Now, infants are normally flexed to begin with, but these infants are super tight and they're kind of jittery almost, where they're so tight, and these are abnormal findings. So it would be a flaccid infant that just laid there with its arms flat out and legs sprawled out. It wasn't tucked in at all. It wasn't flexed at all. That would be abnormal finding for a hypotonic infant. Their cry should be vigorous and medium pitched. If they have a really high pitched cry, this is abnormal. Does anybody know what that could be indicative of?
Could be pain.
It could be. It's usually, this particular type of cry is not necessarily pain.
Seizures?
No, those are good guesses.
Is it some sort of brain damage?
Potentially, yes. Potentially, it could be a neurologic issue. So these are infants that have this, they will have almost this high-pitched cat-like cry. I can't even describe it to you, but if you've heard it, you would know it. And so it could be indicative of neurological issues, and also drug babies. Babies who are born addicted to drugs have this high-pitched cat-like cry. It's very disconcerting and problematic in the fact that here these parents haven't been able to cope in general, I'm assuming, since they have reached out to drug therapy to help them with life. And now they're going to have this baby that cries with this horrific, it's a horrible cry. I'm just going to say it's a horrible cry. So that needs a lot of education on their part, and making sure that they've got some support systems and some help, and figure out how to deal with that. All right, reflexes. We've got the rooting reflex, sucking reflex, swallowing reflex, plantar and palmar grasp. I'm going to show you pictures of all these. The stepping reflex, Babinski sign, the Morrow reflex, which occurs until they're approximately 6 months old, and the tonic neck reflex. So this is a Morrow reflex. This is what happens when the baby, if you hold the baby and then you kind of like do like this, like you're going to drop it, it will do this. This is the Morrow, puts its arms out in a C, its hands kind of curve in like a C shape. If you just come up and you smack the bed beside them, they'll do that. That's a normal reflex. That's a good reflex. That's the Morrow reflex. This one right here is the tonic neck, or the fencing reflex. So this is, they're in a fencing position. They're looking, their head is facing the arm that's out and the other arm is flexed. This is a stepping reflex. If you hold the baby up and their feet touch any surface, they automatically start picking their feet up like they're stepping on something. This is the rooting reflex. If you rub on the baby's cheek, the baby will turn its head that way, assuming and hoping that there's going to be food that way. So when you're ready to feed the baby, or you're breastfeeding or bottle feeding, you can rub on the cheek. You know, if they're kind of all over the place and frantic, you rub on their cheek there and they'll start turning that way for wherever the nipple is. This is the Babinski reflex. And so with the Babinski, you take your finger and you rub your finger from the bottom of the heel up across the top of the toes. And if the toes fan out, that's a Babinski reflex. That's a positive Babinski, and that is very normal for infants. I don't think you all have gotten there yet, but that is not a normal finding for adults. In fact, that's a test that they will do on adults to assess for neurological damage, is a Babinski. And if a Babinski is positive in an adult, that's a neurologic, that's a sign that there's some neurologic damage. This is the palmar grasp in the palm of the hand. If you put anything in the baby's palm of the baby's hand, it will grasp it. It doesn't really matter what it is. So, you know, parents and grandparents, oh, the baby's holding my hand, and yes, the baby is, and that's really sweet. It's a reflex, but they don't have to know that. They're enjoying it, and that's what matters. And same thing with the foot. That's the plantar grasp, is that if you put anything on the baby's foot up around the toes will start curling in, and that's the plantar grasp. All right. Questions about any of those? We're moving right along. All right, Children's Hospital Unit should be cheerful, casual atmosphere. The nurses usually will wear colorful scrubs, and used to be that we could all wear different scrubs. Now, then we went to the nurses all had to have the same color scrubs on, but they still allowed for pediatric nurses to have their own scrubs being very colorful in order to promote the comfort and fun for the kids. All right, they always have a playroom available on the pediatric unit, and they have child life specialists. And these people actually have a degree in child life. I don't know what this degree is, but it is a real degree. And they have to be trained in how to handle kids of all ages and what they like to see and do and play. And I mean, even I think about child life for younger kids, but even when my son was in the hospital a couple of years ago as a teenager, they came around and they offered video games and movies and you know, things that even the teenager would want to be doing. So it's not necessarily just for infant, toddler, preschool, school age development. It's for everything. You know, they do all age ranges to keep them comfortable. So sometimes kids can't get to the playroom, and that's again when they'll call the child life specialists in. You often will have a treatment room so that any major procedures or treatments are not done in the child's room, so they don't associate the pain in their own room. If you have to start an IV, you go to the treatment room. If you have to get an injection, you go to the treatment room. If you know, anything that could be potentially bad, quote unquote, for the child, you take them to the treatment room for those procedures so that they don't associate it with their room. Okay. They'll have child-sized furniture and colorful color schemes, consistent caregivers when possible. So, you know, I think that's really important across the board, no matter what the age group is, but especially in children. If you're working 3 12s in a row, you should have the same patients all 3 of those 12-hour shifts. Or, you know, if the same child is there, you should have that child so that they have this consistency. They get comfortable with you. Encourage the parents to room in with the children and try to keep their routines as much as possible, whatever their routine was at home. You know, obviously that doesn't always work because we have things we have to get done and medications we have to give at certain times and checks we have to do at certain times. But if it's just a routine, you know, the physical assessment we have to do every day, it doesn't mean that just because we like to do it at 7 a.m., we have to do it at 7 a.m. We have to adjust as well to modify to whatever their home routine was to keep everything as comfortable as possible. All right, child's reaction to hospitalization. Let's see, I see it's 150. So let's go ahead and you guys can go ahead and take a little break because I've got to, I got to get up for a minute because my butt's hurting from sitting here for so long at this computer. We can shorten it if you want to and just do 5 minutes or something. Do y'all want to just do a 5-minute break, or we can do the 10-minute, whatever y'all want?
5.
Is everybody good with 5? Okay, I see a bunch of 5s. Okay, so we'll just do a 5-minute break. So just take a quick 5-minute break, and then we will come back and I'll continue here. Let me. All right. Okay. Okay. I guess we'll go ahead and start back here. The child's reaction to hospitalization. So, all right. Preparing the child for hospitalization, each child will react differently to hospitalization based on many different factors. The age of the child, the amount of preparation they've been given, security of their home life, previous hospitalizations and what they've experienced, support of their family, the child's emotional health. So there's many, many different factors that are going to go into how the child reacts to being hospitalized. Some children will exhibit temper tantrums and others start withdrawing when they've been hospitalized. So some of them just go on, life is normal. It just kind of depends. Major causes of stress for all children are separation from their parents and fear of body intrusion. So even in older kids who don't necessarily rely on their parents in the hospital in an unfamiliar environment and they're not sure what's going on or what they're doing, who's doing what, they probably don't necessarily admit it, but they really do prefer to have that parent support there with them. All right, separation anxiety. What age does separation anxiety normally occur? We have 3 stages of separation anxiety, but at what age does separation anxiety normally occur?
6 months?
Yes, about 6 months of age approximately. All right, 3 stages of separation anxiety. We have protest, despair, and denial and detachment. So in protest, the infants cry continuously until they fall asleep in exhaustion. In despair, the children appear sad and depressed. They withdraw from strangers. They don't play. They will often actually protest when the parents do arrive. And this is actually a good thing. And denial, the children become detached from the parents, disinterested in the parent visits. They become much more interested in their surroundings, their toys, different playmates. And this is a coping mechanism that they use to reduce the emotional pain of the parent leaving. It's kind of like, if I don't get attached to my parent being here, then it won't hurt so bad when they leave. Okay. So the nurse's job is to intervene and to educate and to help solidify that parent-child bond.
Can you go over despair one more time? I'm sorry.
What did you say? I'm sorry.
Can you go over despair one more time?
Yeah. So in despair, that's when children appear sad and depressed. They withdraw from strangers. They often won't play. And one thing that they do that's interesting is that they will often protest when the parents arrive. It's not like they're all excited to see their parents. They're kind of like a little bit standoffish at first, but that's actually it's a good thing. It's a developmentally appropriate part of this separation anxiety.
Can you
Sometimes
say
the
those 3
parents.
again? I'm sorry.
I'm sorry.
Can you say those 3 steps again?
I'll tell you what they are, but then if you probably just want to go back and do the recording, because it's all
Yeah, I just
recorded.
didn't get the names of them.
Sure. Protest is the first one. Despair and denial and detachment.
Okay, thank you.
Sure. Forgot what I was going to say, or if I was going to say anything. All right, pain. So pain is whatever the person experiencing the pain says that it is, existing whenever the person says that it does. Okay. So even if we don't feel like they're exhibiting symptoms that they're in pain, it doesn't matter. If they say they're in pain, they're in pain. Freedom from pain is a basic need and right of every person, including infants and children. So what are interventions for mild temporary pain in children? What can we do? The child is having some mild temporary pain. What measures can we do besides medication?
Distraction methods.
Distraction is a big one.
Or console them.
Yeah, consoling or comforting, or if they have a lovey or a special stuffed animal, or getting them drawing or playing with a special toy or anything like that, those types of distractions. Be sure that you do need to still use a pain scale to determine the child's pain level. And we have figure 21-2 in your book, but what is the pain scale called that we usually use for children?
Wong-Baker.
The Wong-Baker-Faces pain scale, yeah. All right, pediatric responses to drugs. So pediatric pharmacology, drug elimination from the body may actually be prolonged in pediatric patients. Why is that? How are most drugs processed, I guess, in the body?
Their kidneys are underdeveloped.
Well, their kidneys are underdeveloped. However, where else are most medications processed?
Liver.
Immature liver.
In the liver. It's an immature liver. They have a very immature liver. And actually, they may have greater renal clearance in toddlers than in adults. So the reason primarily is that immature liver. All right, medications have to be calculated by weight, expected metabolism, sorry, and clearance. So in that conference I just went to, they talked about this a lot too. In certain medications where the nurses on the units were getting frustrated because the pharmacy people were requesting all these labs, and the reason that they were requesting all these labs is because, you know, we don't have this great number of studies done on pediatric patients and how they're excreting these drugs and what's the therapeutic level. And so what they have to do is sometimes keep drawing these labs on children specifically, so they know exactly how that specific child is excreting these drugs, or how that elimination is occurring, so that they can make sure that they are modifying the dosage of the medication. But pediatric medications are calculated in milligrams per kilogram per dose. So that's how you all will often see orders, and I know you all have worked on some drug calculations like that with Miss McCarty, and that's something that you want to honestly not forget, because it's something that you may have to use. Okay. Fear for children, fear and regression. Intrusive and invasive procedures are fear-provoking and cause children not to trust caregivers for fear of pain. So the one time that you go and start an IV on this child, now this child associates you with pain every time. And sometimes that's just the way it is, but that's also why any type of education or talking or role playing, putting the child in a separate treatment room instead of doing it in their room, all of those things can help. You do want to respect the modesty and integrity and privacy of the child, even though, just like with adults, sometimes we get kind of lax on that because we're just like, oh yeah, we've seen it all. It doesn't bother us that you're, butt naked right here. We're good with it. We're used to it. We need to see it. It's bothersome for the client. So you want to be sure that you respect their modesty as much as possible. What is regression?
The loss of an achieved level of functioning.
The loss of what?
An achieved level of functioning.
Yes, the loss of an achieved level of functioning. So it's basically when a child kind of goes back into a younger age or a younger developmental stage. Is this a normal process for children to regress?
No.
Jen says no.
Yes.
Yes. Typically regression in and of itself is not necessarily a normal development, but it is normal for a hospitalized child because now they've got this traumatic experience going on. And so it is a common thing for a hospitalized child to do, is to regress to a younger age. So should we punish, or should we correct, or quote unquote get on the child for this regression? No. I mean, this is a normal phase, especially with hospitalization, and we definitely don't want to punish them or kind of get on them for that. Cultural responses. The nurse must be aware of her own cultural biases first. You want to use, can you use family members for interpreters? I see lots of heads shaking no, and that's correct. You absolutely do not want to use family members for interpreters. You've got to get a language line or an interpreter in-house or whatever it is, but you cannot reliably, legally document conversations or whatever via family members. I'm not saying I've never used a family member. I mean, you got to sometimes, but for true teaching, education, communication purposes, you really want to make sure that you have that access to the language line. And even if sometimes I've had people, family members say, well, I'm right here, why do you have to call the language line? And I have to explain to them that legally I have to have a true interpreter interpreting the conversation, because I have no idea what they're saying. I don't know if they're mixing anything up, but when you're talking to an interpreter on the language line, if they are not understanding what you're saying, they will ask for clarification, whereas a family member may just kind of go on and say whatever they think you're saying, but it may totally be the wrong thing. Sometimes families in the cultural aspect for children, not only children, but everyone, is they may have these protective amulets. Do you know what those are?
Is it like something that goes with their religion?
Yeah, it's kind of with the religion of their culture. One example that I have written down here is gypsies. Hold on, I can't read my writing. I think it's supposed to say fear. Gypsies fear red and the number 3. So a red medication given 3 times a day will get, no, they are for that, I guess, because it says a red medication given 3 times a day will get more compliance than a white medication given 2 times a day. I mean, I don't think about that enough to think about what the medicine is, what color it is, but in gypsy, you know, in certain cultures, that's really important. I know sometimes we've had cultures where they will pin little things to the babies, to their blankets or to their clothing, their onesie or whatever. And, you know, you want to honor that and allow that to happen as long as it's not a safety problem. You know, obviously if there's a safety issue, then we're going to kind of jump in and do some education, but as long as it's safe for everyone, you want to allow anything, any cultural practices that they have to go on. All right, so culture determines our personal space. Smiling is not perceived as being friendly in all cultures. Okay, these are things you don't think about because you're just assume, oh, that's what people expect. They expect you to be smiling at them. Well, not necessarily, because that doesn't always mean that's a friendly thing. Eye contact in some cultures can be seen as disrespectful or rude. In the Asian culture, sometimes eye contact is disrespectful. In Native Americans, sometimes that's a rude. In American cultures, that's very respectful to have eye contact. When you are doing your teaching or talking or communicating with patients, you can't just assume either, oh, this is an Asian client, so they're not going to want me to have any eye contact. You kind of have to ask them and get a feel for where they are with their culture, because they may be Asian and still doing some of the Asian culture things, but very much have grown up in an American culture where if you give them no eye contact, they may see that as being disrespectful and rude. So you may have to ask questions, you know, what is considered normal in your culture, or what would you prefer, or whatever. Okay. Touch can be misleading or it can be friendly. In the Vietnamese culture, sometimes touching of the head, they think that robs them of their soul if you touch their head. Some cultures like to focus on the current issues, while others like to focus on the long-term impact. Does anybody have anything? Because I think culture, this is a really good aspect, you know, that somebody else may have something to add as far as a cultural preference that we can add in there.
I have a like a evil eye thing from when I was a baby, and my parents had pinned that to me for a while just as a child. So that's one thing that in my culture, we do.
Yeah. And I can't even remember, it's been a while what it was at the time, but I just remember that one time I had a patient that had something pinned to the child. And, you know, like I said, we try to honor that as much as possible, as long as it's not, you know, a safety factor, we'll honor that. Anybody else? No? Okay. Parent reaction to the hospitalized child. So parents can have a sense of guilt for the child being hospitalized. The nurse must remain objective and empathetic, okay? Parents usually feel helpless when the child is hospital, as they are now losing that protector role. That's kind of now what the nurse is doing. And so sometimes they feel like you're stepping on their toes as the nurse, you're doing their parenting job, and you just want to make sure you get a good rapport with the parents and they understand that you're not trying to take over on their role or anything. So any questions you can ask them, you know, any participation they can do, you should really try to encourage that participation of caring for the child. So what should nurses do to help parents?
I would say education, because a lot of times the kids feed off of the parents' energy. So if they know that it's a simple procedure or something.
Yeah, that's a big thing. Yeah, so informing the parents of the child's treatment and conditions, explaining all the equipment that's in the room, how it's working, that just gives them a little bit more power. Reinforce their positive parenting, you know, make sure that you're relaxed and reassure the parents frequently. And, you know, really asking for that parental participation is a big thing, because like in the NICU, let's just say your infant is in the NICU, sometimes parents get really reliant on the nurses to provide the care, and they don't want to do the care anymore. And sometimes you kind of have to, I don't like to say make them, but you have to really, really encourage them to start taking care of the infants, because they're afraid the baby's too small, or they're going to hurt the baby, or they don't know what to do. The nurse knows what to do. The nurse does it better. The nurse this, the nurse that. But, you know, we have to encourage that parental role and what they can do for the infant, and try to get them involved. Sometimes, I'm just going to tell you, it's a lot easier if we did it all. It's way easier, but it's not ideal. It's easier if we feed the baby. It's easier if we bathe the babies. It's easier if we do all of that stuff. But that's not helping anyone except us and our schedule, and that's not our goal. So our goal is to prepare the parents to take this baby home. So, you know, really encouraging, demonstrating, and facilitating that parent involvement is very helpful. Siblings are also affected when a child is hospitalized, so they sometimes will feel left out. They may feel guilty or resentful. So if the siblings are coming to visit, the nurse should really try to direct some attention to the sibling, ask them questions. How old are you? What's your name? You know, what do you like to do? What grade are you in? You know, everyone in the family is affected when a child is hospitalized, and that goes all the way up through, you know, the teenage years. If the teenage child is hospitalized, that still affects the whole family, because still likely at least one parent is going to the hospital, and that again disrupts everyone's normal routines. All right, the nurse's role. So admission, when we do admission, empathy when admitting children goes a long way towards making this a very positive experience. Separation anxiety occurs, what ages again?
6 months.
A little bit. Yes, it can start at 6 months. To how long?
Adolescence? Yeah.
Generally about 3 years. I mean, that's when we got true separation anxiety. Yes, even up in the adolescence, they're going to want someone to be there, but they certainly aren't going to tell you that, and you're not going to see it in their actions necessarily. But, you know, usually at least till about 3 years. You know, after 3 years of age, they begin to get worried about what's going to happen to them in the hospital. You know, if possible, if you can prepare the child for the hospitalization, that's better. Explain anything that's going to happen, what's going to be going on, what are you there for, anything that you already know or that the physician has already told you, you really want to try to explain to the child. When there is a good relationship between the nurse and the child benefits from higher quality of care. You know, as an older child feels like they can ask questions, or even if that relationship is there between the child and the nurse or the parent and the nurse, those relationships will help to have a better quality of care. If the parents feel like they can't ask the nurse questions, or the nurse blows them off, or the nurse is hateful, or she's always in a hurry, those things are going to really distract from the quality of care that the kids are getting. Developmental history, we're assessing the family relationships, the family dynamics. I'm amazed all the time at the interesting family dynamics that people have. Good, bad, or indifferent, that's not for me to judge, it's just that they're interesting. So we need to figure that out. Cultural needs that may affect some of their care. You know, some cultures don't allow men as providers. It depends, you know, there's a lot of different things lots of different cultural aspects that we need to look at as far as providing the best care. Does the child have a nickname, or what do they go by? It's just like you guys as students, you know, one of the first things I do in class is, you know, is this the name you want to go by? Is this the name you want to go by? I'm not going to call you Abby because I see you there. I'm not going to call Abigail when she's told me she goes by Abby. If I continuously still call her Abigail, I mean, that looks really bad on my part. Like I didn't listen to what she requested of me. And same thing as the nurse patient. If they say, you know, oh, well, we call him whatever, Jim Bob, that's what we should respect, okay? Any rituals or routines that they have, we really want to try to stick with them if at all possible. We need to understand the developmental level that the child's on, and you guys are going to work on that in second semester as well. You'll have hopefully one day of a pediatric rotation where you are really, really focused on developmental levels of children, their communication skills, personality and coping skills, any past experiences, divorce, new siblings, extended family. We need to know the gamut so that we understand where this child is coming from. Previous separations, has the child been hospitalized before, or had to stay with someone overnight for long periods of time before? What is their previous contact history with healthcare providers? And has the child been prepared at all? All right, then we're going to get some biographical data. So we need to know the child's name, address, phone number, caregiver information. You always want to have a way to reach the caregiver. What is their best phone number to be reached at? You know, should they leave? And usually in younger children, especially, there'll be some kind of code or ID number you have to, if you want to call and talk to your child or talk to the nurse about your child, you have to give them a number. So usually it may be like the admission, the bracelet that they would put on you at admission. They would put one on the child and one on each parent or whoever is there. And that way, if you want to call and ask about your child, you have to call and tell who you're calling about, the child you're calling about. And then you have to give off certain information off of that ID band so that they are not violating HIPAA and telling somebody else about your kid. Newborn assessment should be done within the first few hours after birth. It is usually done in a warm area under an Ohio bed warmer, an open warmer, so that you can unwrap the baby, see everything, do that good, full, complete physical assessment, because remember, it is super important to be able to notice any of these skin changes, skin colorations. And sometimes we just take for granted things like the polydactyly and syndactyly. You overlook it because it's not real common. We don't see it all the time, and you may not even recognize it because you're in such a hurry and you're just like, yeah, everything looks good. I mean, that's one for me. I had to really start making sure that I actually counted fingers and toes, because I was just like, oh yeah, it looks good. I mean, nothing was super abnormal, but I wasn't necessarily really paying close attention. So it's one of those things that I started recognizing as I through the years as I kept doing it over and over again. And so then I started paying very particular attention and making sure that I was doing a good full assessment on that initial assessment. You know, you got to recognize when you have breaks in your care as well. You don't always provide the best care. That's human nature. So you've got to be able to recognize, though, you know, a good nurse will recognize when they do have some of those not best practices, and try to be specific and conscientious about fixing those things. We're all human. We're not going to be perfect. Vital signs, respiratory rate tells us how well the infant is adapting to extrauterine life. Now, we do a respiratory rate first for the vitals. Why is that?
To get a baseline.
I can't hear you, sorry.
To get a baseline.
We are getting a baseline, but as the vitals itself, why do we have to do the respiratory rate first? Why do we do respiratory rate before temperature or before pulse?
Because once you start fooling with the child, it's going to be crying and harder to get.
Yes, so that's the primary reason. They're usually asleep and quiet, and so that's why we're going to do the respiratory rate first while they're asleep and quiet before they start fussing. So infants are abdominal breathers, so they're belly breathers. So we are monitoring regardless of how they breathe, but we need to monitor for signs and symptoms of distress. So what are some signs and symptoms of distress that we've talked about? Respiratory distress.
Nasal flaring.
Nasal flaring. What else?
High-pitched crying.
High-pitched crying is not necessarily distress. It means that there is something else potentially going on, whether it be an infant that was born to a mom addicted to drugs, or whether there be a neurological condition. So yes, that is something that is alarming, so to speak, but not necessarily something that tells us that the infant is having any respiratory distress.
The contracting,
What is that?
whenever, like the respiratory distress.
What is she trying to say?
Retractions.
Yes, thank
There
you.
you go. Retractions. So that's when the baby is breathing really hard, and you can see the ribs literally as they suck in. They'll be breathing so hard that when they suck in, you can see their ribs. So they'll have retractions, nasal flaring. What's another one?
Anything over their normal, isn't it 30 to 50, or not 50?
I skipped that question. I should go back to that. What is the normal newborn respiratory rate? I skipped that question.
Is it 30 to 60? Or am I going way too far?
No, 30 to 60. 30 to 60 breaths per minute. Is it a regular rate and rhythm for newborns?
It's sporadic.
Right, it's very sporadic. Yes, so they may have these periods, a few pauses of apnea, and then they'll, breathe in real quickly a couple times. So it's very irregular breathing pattern. That's normal. But again, signs and symptoms for distress would be things like the nasal flaring, retractions, could be a tachypnea, that elevated respiratory rate, so anything over 60. Stridor, they've got stridor. We talked about that a long time ago when we did respiratory physical assessment. Remember when they, on inspiration, and they just have that noise where it's closing off there. They may have grunting, where they, again, are struggling with respirations, and they are almost kind of like, some parents will be like, oh, he's singing to me, he's kind of just fussing a little, where they with every respiratory rate, and that's them trying to push and keep those alveoli open, but those are signs of respiratory distress. So why do we need to count an infant's respiratory rate for a full minute instead of doing that 30 seconds times 2? Why do we need to do that? We've already kind of touched on it.
Because they're irregular.
Right, because their breathing is very irregular. We can't just do this 30 seconds times 2 for them. We may get, our numbers would be really off. So we really do need to count respiratory rate for a full minute on infants. We can check pulse oximetry. They usually will put a pulse ox around the foot of the infant, and it looks like this usually, this little, it's kind of like a stretchy rubber, stretchy Band-Aid kind of. They'll put it usually around the foot. We can do it around the hand as well. They have them where they're plastic, almost like a little blood pressure cuff type thing as well, but different routes that you can use. Generally, we pretty much always put it on a foot or a hand. That's where I've always used a pulse ox for an infant. How often do we need to change the site? Not two. Yeah, every 4. We're going to change the site every 4 hours. How often are we going to check the site? Check it every 2. Check the site every 2 hours, change the site every 4 hours. Why do we have to do that even?
Prevent the skin breakdown.
What'd you say, Abby?
Prevent skin breakdown.
Yes, because we're assessing and trying to check for skin breakdown. If we keep the pulse ox on the same foot or the same hand for long periods of time, that skin is going to start breaking down. We also need to check the alarm settings at the beginning of each shift, because the previous nurse may have changed the alarm settings so that it didn't beep when the ordered parameters are set for. Sometimes they do that. I'm not saying that's bad or whatever. It's just something that you need to make sure that you've checked, so that if you're going to rely on that pulse ox, you need to make sure that it's going to beep when you think it's going to beep. So just because the parameters say that it should be beeping if the pulse ox, if the O2 sats drop below 80%, if you don't check that and make sure that that's what the O2 monitor is actually set for, then somebody may have accidentally or purposefully changed it to not beep until it was 75%, until the O2 sats were down to 75%. So if you're going to rely on that,
Oh, you forgot.
you need to be checking that.
FaceTime.
Okay. All right, heart rate. What is the normal newborn heart rate?
Isn't it in like the 100, 130?
There's a range. What's the range?
30
So
to
160 maybe?
110 to 160. 110 to 160 beats per minute. When you're listening to the fetal heart rate, you also want to assess and note for any murmurs that you may hear. You're going to count the apical pulse for 1 minute in the newborn. And for an older child, you can do the radial pulse for 30 seconds and times it by 2, just like we do for adults, as long as they have a regular rate, regular rate and rhythm. You're going to assess the quality, the rate, and the rhythm of the heart rate. If they are on a cardiac monitor, you're going to check those electrodes every 2 hours for any redness or irritation, as well as security, to make sure that they are secure to the skin. Because again, that's going to go off, you're going to rely on that, and that starts beeping. It's going to make for a long shift if it's just due to the fact that these electrodes have fallen off. But if they keep falling off and you don't check the skin, it may be falling off because there's some redness or irritation or complications as to why they keep falling off. So I just can't stress that enough, because I think that, well, I don't think I know, as nurses, we tend to not always see the whole picture because we're always in a hurry, and it's like, yeah, just throw those electrodes on, and I don't have time to keep checking that. They fall off. Well, let me just stick another one on. Why do they keep falling off? I mean, sometimes they just keep falling off. There is no answer, but sometimes there is an answer that we are not really looking into. All right. Temperature. What's the normal temperature for an infant or for a child? No, listen, only a few of you have piped up. I got lots of you on here. What's the normal temperature? Give me a guess.
98.6.
Okay, 98.6, that's our normal temperature. What's a range? What's the range?
Is it to like 99.7?
It does go to 99.8. What's the bottom?
Is it real low, like, or what I would consider low, like 95 point something?
No, it's not that low.
No,
That's too
not
low.
that low. 96 point something.
That's too low.
96. No.
You just good guessing. That's really low.
97.8.
Your book says 97.1. So that's what we're going with. In practice, it's usually, from my experience, a little bit higher than that, but this is what your book says, so that's what we're rolling with. 97.1 to 99.8. You can take a temperature orally in an older child, rectally, axillary, tympanic. What's tympanic?
Ear.
Ear. Or temporal. What's temporal? Across the forehead. Yeah. Now you have to be careful with especially the tympanic thermometers in young children, because their ear canal, the eustachian tubes, the ear canals are shaped differently, and they're very shortened and small, and so oftentimes those tympanics are not don't give you an accurate reading for children. All right, so oral for children older than 5 years of age, for the conscious child, obviously, and for the cooperative child. Now, the whole adding a degree, subtracting a degree, I don't ever, I teach not to do any of that, because I think you should document exactly the number that you get and how you got it, and it's up to the physicians to interpret that or determine if they want to add the degree, subtract a degree, yada yada yada. I don't think that that's our position to do, because there seems to be some controversy on that. So I always tell everybody just to take the temperature the way you're going to take it, document the temperature you got, how you took the temperature, and if that prompts you to call the physician, you're going to call the physician and tell them the temperature you got and how you took the temperature. If they request you take it another way, you would do so. Rectal temperatures can be taken in infant and young children less than 4 years old per your book. It is not recommended for pediatric patients. It is controversial. Every semester I look this up and try to find more information on what is evidence-based practice, and it's still very controversial on whether or not to do rectal temperatures in anyone, really. Axillary, which route is axillary?
Armpit.
Under the arm.
Sorry, my dog was barking. Yeah, under the arm. So if we do an axillary temperature, we need to ensure that there's skin-to-skin contact, there's no clothing in the way. This is how we typically do infant temperatures, is to get a thermometer. But again, you want to be sure that you get the thermometer up in the armpit really good, and there's no skin no clothing that's going to block it, and that it's going to be skin-to-skin when you put that arm down, covering that thermometer to get a good temperature, okay? But regardless, if you take it temperature axillary, you're going to write down the numbers and put AX. If you take the temperature rectally, you're going to write the numbers and put R. If you take the temperature orally, you write the numbers and put O. Tympanic, you would put, usually you may have to spell tympanic out. I don't really know how they would abbreviate that, or maybe just 2 by M, and same thing with temporal, TEM. But you can see how that could be confused as they're very close. So often I would think you would probably write that out completely.
I have a random question about babies who are cooling. Is there a specific way, or can you still do it axillary and still get an accurate temperature?
What do you mean they're cooling?
Like if they're on a hypothermia protocol and they're on the cooling blankets, because doesn't that drop their core temp?
Yes, it would. Honestly, I've never experienced that. Usually we warm the babies because they drop their temps, so they have very difficult time maintaining their temperature, and usually what happens is their temperature drops. I've never had to cool a baby. I've had to warm lots of babies, and doing that, we do that just with an Ohio bed warmer, an open warmer that has the heating element at the top, And yes, we still will check axillary temperatures, even though we're warming it with this radiant warmer, this Ohio bed warmer that the heat is at the top. Does that make any sense?
Yeah.
I know whenever we've had a few babies that we've had to use the cooling blankets on, and they told us that axillary was still considered the best way.
Okay. Yeah, I mean, I think that I wouldn't see a problem with it, like I said, because we're using, when we warm the babies up, we're still doing it axillary. So I would not think that would be an issue. Good question. All right, with the blood pressure is a part of routine screening for children greater than the age of 3. They do usually do blood pressure on infants initially, and sometimes if they've got some kind of cardiac anomalies, they're going to do more blood pressures and do blood pressures in each extremity, but routinely, not every baby is getting a blood pressure. And but after about age 3, when you take your child into the doctor for a regular well child visit, they're going to start doing these blood pressures. And blood pressure seems pretty basic, but that can be kind of scary for kids. So, you know, you need to explain to them. It's like giving your arm a big squeeze, a big hug. And something else that you've got to be careful is using the appropriate cuff size. They're not miniature adults, so you've got to make sure that you are using a pediatric cuff, the appropriate size. It should cover 2/3 of the upper arm to get that good reading. And I hate that I'm not going to be able to show you guys stuff that I don't even know if I've got it here. I literally went into the school last week and just brought tons of stuff home, but I don't know exactly what I've got, but I've got these little teeny tiny blood pressure cuffs that we use for infants sometimes. All right, nursing care plan keeps the focus on the child, not the condition or the treatment. It may require some modification for the pediatric patient. It also includes evaluating the caregivers, because caregivers have a direct role in the safety and maintenance of the child's health. I mean, the child can't take care of themselves, so it does relate with the caregivers. Play is a huge part of a nursing care plan for children. That is part of their developmental need, and achievement of developmental tasks should also be included in that care plan. So, meeting needs of the hospitalized child. The hospitalized infant, their daily schedule is disrupted. Breastfeeding is likely disrupted. We're probably doing tests or sending them out for testing and doing labs and everything. And so breastfeeding likely will be disrupted. We really need to try to meet the needs of the infant by protecting them from any excess frustration. So anything we can schedule around their normal routine, around their breastfeeding schedule, we want to do. And sometimes we can do that. We don't always take that initiative, and we should. So we need to also assist with the parent-child attachment, and we need to promote sensory motor activities, promote ways for the parent and child to interact, be a role model, cuddling, rocking, talking, singing to the infant. This is not our child, but we are treating it like our child, especially while it's in the hospital. So we need to be nurturing, okay? Perform uncomfortable procedures as gently as possible, and then return the infant to the parent for consolation, to be consoled. So if we're doing a procedure that is uncomfortable, like starting an IV or giving an injection or any number of things, even a newborn, if we're doing a circumcision or a heel stick for blood draws, we want to do the procedure as gently as we can, as quickly as possible. And then when the parent is available, we want to return the child to the parent for that comfort and consoling. Right, consistency in caregivers, we already talked about. Nurses need to spend time with their patients. You need to have liberal visiting hours. So we can't be on this strict, you know, I mean, right now we would be regardless with this COVID-19. Obviously, we're going to be on very strict visiting hours, but in general, on a pediatric unit, you have to be a little bit more flexible with your visiting hours, because and the number of people that are there. I mean, it can't get out of hand, but the point being that we've got to just promote the best, most comfortable environment for the child, however that works out. All right, if the hospital allows toddlers can't understand why they're separated from their parent. There's information in box 21.2 in your book. We need to have cohesive staff. Frequent parent visits are necessary. Separation anxiety is at its peak, so you got to be prepared for that. Any type of security object from home really helps. A blanket, you know, a lovey, or their favorite stuffed animal, or their favorite toy, or anything that helps them feel more secure and more comfortable is very beneficial. When the parent does leave, tell the child when they're going to return in relation to something that they're going to remember. You can't say to the child, oh, well, your mom will be back at 2 o'clock. Okay, that doesn't mean anything to a toddler. So you've got to give them some kind of relation, something that means something to them. So, you know, your mom is going to come back after lunch, or after breakfast, you know, it's time for bed, and, you know, mom will be back after breakfast in the morning. Something that they can relate to. And you do want to try to be, it's just like with your adult patients, you want to try to be as truthful as possible. If you don't know, don't lie and say something. You know, usually parents will tell you, you know, I'll be back at this time, I'll be here at 9 o'clock. Well, that's fine for you, the nurse, to know, but that doesn't mean anything to the child. So you've got to relate that 9 o'clock to something for the child, so that the child knows what that means. But, you know, and also part of that is going to be education for the parents, in helping them to understand that when you say you're going to be back after lunch, you know, when is lunch? So lunch for us maybe, you know, 12 o'clock, lunch in the hospital maybe 11 o'clock. So we need to make sure we're all on the same page with what does after lunch mean, and we really need to encourage the parent to be back at that time, so that the child realizes that they're not being abandoned, that the parent is coming when they say they're coming, and things like that. Hugs and kisses and prompt leaving, no lingering. You know, some parents want to, it's just like dropping their kids off at daycare. Sometimes they will linger and they want to talk forever, and they hold the child the whole time. And I mean, that can go on for like 45 minutes to an hour, even if you're just dropping your kids off at daycare. So we've got to really encourage that you say your goodbyes, give them their hugs and kisses, and then that you go ahead and leave, because that lingering just drags things on and makes it more uncomfortable for the child. And, you know, one thing that you can always do, nobody wants to leave their kid in the hospital. So things you have to make sure, even an adult, is that, you know, reassure the parents that you will notify them if something happens. You know, make sure you have the correct phone number, and that you do notify them. If something does happen, you really need to notify them. It may not even be something hugely important, but speaking from personal experience, it gives you a much better comfort level in knowing that you can leave, because they really will call you if something happens. And then you make the decision on whether you need to come back to the hospital or whether they can handle it on their own or whatever. All right. Parents should or should not slip out when the child is asleep. What do you think? I see a lot of heads shaking no, and that's correct. They should not slip out. Sometimes that's the easiest thing. They're like, let me just get the child to sleep, and then I'm going to slip out and go home, go to bed, and I'll be back before the child wakes up. Well, you don't know you're going to be back before the child wakes up, unless the child wakes up in the middle of the night. But what that does is cause a huge distrust for the child. When the child wakes up and the parent is gone, they're taken aback, because that's not what the plan was. They went to sleep and the mom was there, and now the mom is not there. Okay, so you can't tell the parent how to parent, but what you can do is encourage, as the nurse, here's what your experience has been, here's what you've seen. It's really best that you not do that. While I know it may be easier for you now because you don't have to go through the drama of the child crying and hanging on to you, it's really not best in the long run for the child. If parents don't want to care for the child while in the hospital, is that okay? And should the nurse make the parents care for the child?
Can't really make anybody do anything, but you can try to encourage them to, you know, care for the kid.
Right, exactly. I can't really make them do anything, but I can encourage them. You know, I can refer refer out to a clinical nurse specialist to evaluate the family dynamics. If I'm really concerned about something going on with the family dynamics, if the parents, you know, just kind of refuse to care for the child, whether that be social services or whatever, somebody that can dive a little bit deeper into that and figure out what is going on. Why are they not wanting to care for the child? Are they capable of caring for the child? Which most of the time the answer is yes, but maybe they aren't. You know, what else is going on in their life? That's not our job to find out, and we don't need to know necessarily, but we do need to make that referral because for the child's well-being, we have to figure things out. So in the toddler stage, regression is or is not expected at this age. Yes, so I see a few heads. Yes, and that's true. It is expected. Be truthful. Should you be truthful about things that hurt, or tell them, you know, this won't hurt?
You need to be truthful.
Yes, you need to be truthful in what you're telling them. If it's going to hurt, do not tell them it's not going to hurt. You can say to them, you know, this will just be a little pinch. It's only going to last a few seconds. You probably won't even, you know, it'll probably be over before you even know it. But absolutely do not tell them this won't hurt if it's going to hurt, because they will never trust again. And it's not just about trusting you, it's about trusting all healthcare providers. When should you tell the toddler about a procedure? Like, should you tell them a couple of days before the procedure, or a couple of, you know, hours before the procedure?
I mean, I think, shouldn't you do it like whenever you're getting ready to do it? That way they're not like scared about it leading up to the procedure.
Right. Yes. You want to do it as close to the procedure as possible, because you don't want them to have all this time to worry and fret and be concerned about this procedure. You do want to explain the procedure to them, but you don't want to do it too far in advance. What are some ways to reduce anxiety and pain for the toddler?
Distraction.
Yeah, distractions. Bubbles, pop-up toys. I mean, the little electronic toys. There's 100 different things that you can do as far as a distraction to reduce that anxiety and pain for toddlers. But distraction is a big one. Bubbles are something that are so simple, so cheap, and really do work really well for kids. All right, playtime is an important part of care. When any type of restraint is required to keep, the only reason we would really use restraints are to keep the IV in, or burn dressings on, or making sure that they're not harming themselves. But anytime, when any type of restraint is required, we need increased emotional support from the nurse. So staffing should accommodate for the nurse to stay with the patient and the family longer. The parent also needs to give the child extra attention when they return home until that trust is regained, because they were in the hospital and they were in and out and not with the parent all the time. And they've got to recognize that when they get home, it's not like, okay, now we're home, let's get back to our normal routine. Well, I mean, that works for us, but that doesn't work for the child. So they are going to have a little bit of extra attention. They're probably going to be very clingy and, you know, want to hang on to mom and dad, and not go off with their friends and do things unless mom and dad are sitting right there with them. And those are all things that should be expected and anticipated. Okay, so I think I'm going to stop there. So I'll have Miss McCarty start with preschool. And if she doesn't have this, I'll end up doing it, because I can't remember what she's got. What she doesn't have. But somebody, one of us will do this tomorrow. We'll start at preschooler and finish this up. We just have a couple more slides left. So we'll start there at preschooler. Any questions? I did such a great job. You don't have any questions, huh?
Miss Matthews, you might have mentioned it at the beginning, but what about the quiz in the morning? You need to log on right at 9 o'clock.
Yes, so you're going to want to log in right at 1 o'clock to Blackboard. You know, if possible, you can have both open. You can have Blackboard and your Zoom open because right at 9:10, Miss McCarty will go ahead and start lecture, or myself, whoever it is that finishes this one up, will start right at 9:10. So you'll want to be, Blackboard will open that quiz. It's in course materials at the very bottom of the page. You can't see it right now because it's not open to you right now, but it will be. Open to you starting at 9 o'clock in the morning to log in, take that quiz. It's just 5 questions like normal, and you'll have 10 minutes to complete that quiz. It should auto upload. If it does not auto upload for some reason, we can go in and see how long you were in the quiz. If you're in the quiz longer than 10 minutes, then we'll deduct a few, we'll have to figure out how we're deducting, but that's just normal guidelines for any type of Blackboard quiz. If you're in it longer than the 10 minutes in the allotted time, if for some reason Blackboard should allow that, which it should not, it should auto upload within 10 minutes.
Okay, thank you.
Sure.
Would it be set up like how would it be set up when we click on it?
What do you mean, how is it set up?
Like a multiple choice setup, and we just like maybe.
It is mostly multiple choice and fill in the blank.
Okay, so it's like so we just submit it and then it takes it like that? Or?
Yes. You submit it and it may auto grade, even if it does auto grade, especially because I have that one fill in the blank in there. I will go through and regrade them all to make sure that it graded it correctly. So I will do that tomorrow, sometime tomorrow morning. Go through there and make sure that everybody's got graded. But you can't log in after that. I mean, so if you're going to take the quiz, you got to be in at 9 in the morning to take it. Take the quiz. You can log off of the quiz whenever you're done. It's not going to do a review or anything. So whenever you're done with the quiz, you can go ahead and jump back onto Zoom and be ready for the lecture, because it's not going to give you any type of we're not doing a review or anything like that on the Blackboard quiz.
I have a couple of questions. I just must have missed it. For the lacrimal duct, you said that they're usually developed at age 1 to 3 is when they develop?
Months, 1 to 3 months.
No, I think it's 1 to 3 months.
Okay, I was thinking years was too much, but.
Yes, 1 to 3 months. That lacrimal duct usually develops around 1 to 3 months of age.
Okay, and their uncoordinated eye movements is called dog's eye?
Mm-hmm. Doll's eye movement. Mm-hmm. Now, when I have, I don't know exactly what you all can see. When I have you guys on the pictures on my screen, can you all see the pictures, or do you still see the PowerPoint? Right now, do you see the PowerPoint or the pictures?
I can see both.
Yeah.
Oh, so it's whatever you all set up, not what I set up. Because I have your all's pictures taking up most of my screen right now, but you're still seeing the whole PowerPoint. Is that correct?
Yeah.
Okay.
Yeah, we
That
have
helps.
options as to how we can view it on here.
There's
Okay.
like a grid, and there's like 2, and then there's like 1, or whoever's speaking.
Okay. That helps me to know what you get, because I like to see the pictures and I like to be able to look here at the camera instead of looking to the side, because I'm looking at my other screen when I'm looking to the side. But I didn't want you all to not be able to see the PowerPoint. So if you all can see the full PowerPoint, that helps me know better what I can do on my end. Now I have recorded this and I will get it uploaded. It does take it a little bit of time for Zoom to capture it and then for me to get it uploaded onto YouTube and then uploaded into Blackboard. But I will do that this evening. So it should be posted this evening. So you guys can go back and watch if you have any questions. Any other questions?
I had a random question about the Mongolian spots.
Sure.
Is that something that you can, or like when you push, are you can see a color change, or is it just going to stay that dark color?
What's the question now? Can you see a color change if you blanch it or something?
Yeah.
No, I mean, it's just that color.
Okay.
Yeah.
That one I think was a few of those. I was trying to keep up with what you were saying and writing them down.
I know it's kind of difficult, and that's why, I think this recording will be good, although it's a long recording, but you can always kind of just fast forward to whichever slide you're seeing and know where to pick up and listen again.
Perfect. Thank you.
Sure. Anything else? No? All right. If y'all don't have any other questions, I will log off. I'll go ahead and close this out. We'll get it uploaded, and I will send out the announcement thing about the timing so you all will know when to be prepared on Thursday to get your email about your system for the physical assessment. Okay? Yep, Jen.
Sorry, one more. I just wanted to see, so for Wednesday, I mean, are we logging on for like a lecture for the lab, or?
No, because all we were doing was practicing physical assessment.
Okay.
Wednesday's lab lecture was practicing the physical assessment, and Thursday was doing the physical assessment checkoff. So we won't log in or anything on Wednesday. You know, I haven't figured out exactly how to do all this yet, but I'm trying to figure out how to somehow make some kind of virtual office hours so that, you know, there'll be a time when I'm sitting at the computer or whatever so that people can just log in and do like a conversation like this as needed. But anytime until I get that figured out, and at any time, you know, just send me an email or a text or something and I can send you the Zoom invite and we can, you know, have a meeting if you all need to talk about anything. All right. All right. I'll go ahead and log off then. Y'all have a good evening. Maybe I'll log off. I can figure out how. There.